Hi, and welcome to the Curious Cardiologist podcast. My name is Dr. Sanjay Bhojraj, board-certified interventional cardiologist and functional medicine practitioner. In this podcast, I'm going to look at old problems in new ways. We're going to have a series of guests who are going to force us to challenge the status quo and rethink the way we approach health. Because I found in conventional medicine, we really just treat things, but what we need to do is focus on healing. So if that sounds like something that you like, if you're a practitioner, if you are a patient, if you're someone who's just looking to optimize your health, you found the right place. I hope you enjoy this episode. Hey everybody, and welcome to the inaugural episode of the Curious Cardiologist podcast. My name is Dr. Sanjay Bhojraj, interventional cardiologist by training and functional medicine practitioner. As you've heard, the purpose of the Curious Cardiology podcast is to look at old problems in new ways. And I can't think of a more exciting problem to look at in a new way than coronary artery disease, that blockage of the arteries that leads to heart attacks and angina, and what I basically spent the first 15 years of my career dealing with. And today we have a functional medicine icon. Is that what can I say that, Dr. Elyaman?
Dude, it sounds
icon,
good, man.
Celebrity. If we had Kardashians in functional medicine, it would be him. Dr. Yousef Elyaman, educator for the Institute of Functional Medicine on the cardiometabolic side, all around great guy. And as a small piece of trivia, I was his first podcast guest, and therefore I am happy to return the favor today. Yousef, how are you doing, brother? Thank you for being here.
I'm doing great. Thank you for having me. I am so excited that I get to be your first guest. It means the world to me. And you being my first guest when I was still trying to figure out all the buttons was pretty amazing.
Well, and I'm trying to figure them out just as much, so we will struggle through this. Listeners, I hope that you're going to be okay with this. All right, sounds like they're cool. I don't know if that's coming across, but so we're going to talk today about, as I mentioned, something that is near and dear to every cardiologist's mind, which is coronary artery disease. And Yousef, you take a little bit of a different twist. You're actually suggesting that coronary artery disease is an autoimmune condition. Is that right?
%. And it's not like just some fringe opinion. We have amazing data. Like we have research that shows that at least a big part of it is actually autoimmunity, where the body's attacking itself.
But I thought it was just all about cholesterol. I thought that was what caused, right?
Yeah.
That's what we learn in our conventional training. It's about cholesterol, but you're saying the body attacks itself, and that's what leads to these issues.
Yeah. So part of what's happening is the body attacking itself. So cholesterol and how the body processes cholesterol does play a role, but there is research that is showing, and has been for years, showing that there is an autoimmune, kind of like rheumatoid arthritis, lupus, that coronary artery disease and strokes and heart attacks may actually be an autoimmune disease.
Well, and I've heard before, and certainly one of the sentinel studies or papers that really brought me into cardiology was this New England Journal of Medicine paper in 2001, looking at atherosclerosis as an inflammatory condition. And since then, I've really just thought of atherosclerosis as atheroscleritis, which is where we have these circulating LDL particles that can get damaged, and then our body starts to attack these LDL particles because they turn it into DAMPs, right? Damage-associated molecular patterns that the body decides are not something that it wants around, and that initiates the process of endocytosis, of taking those LDL particles into the gap junctions in the endothelium, which is the lining of the blood vessel, and then ultimately into the blood vessel wall. Your research or your background suggests that there's something more beyond that. So what incites that? Is it something more than LDL? Are there infections at play? Are there toxins? Like, what brings this about?
Yeah. So dude, this is exciting. You don't understand how excited I am talking about things like this. So it's like as we start to learn more and more about the human body, and we're putting things together, we start realizing there's more to the story. There's more to the story. There's more to the story. So absolutely, inflammation is a driver. Absolutely, you can have cholesterol leaking in between the blood vessel wall, and when that happens, then you can have those macrophages swallowing them, and there's this inflammatory process that's happening, and the plaque is forming. But this is the uncovered layer, and I'm so happy that this is going your first episode of the Curious Cardiologist is going to talk about this piece.
You're hearing it here first, yeah.
Dude, we're gonna blow up the internet with this stuff. But here's the deal. If you look at, we do know that autoimmune conditions like lupus, rheumatoid arthritis, in your cardiology training, you learned, in my internal medicine training, we learned that people with autoimmunity have a higher chance of heart attacks and strokes.
Higher incidence of blood vessel inflammation, all of these things. Yeah.
Right. It's actually what we call a risk enhancing factor, meaning that if we take all of their numbers and we run them through the risk calculator, you actually have to add to you take a look at a number at what their risk of having an event is.
Right. And then you add this fudge factor of the risk enhancing kind of on top of the normal risk.
Right. Meaning that their risk may look okay, but if they have autoimmunity, it just shoves up their risk a little bit more. So
Absolutely.
we know that.
And in clinical practice, we see this all the time. We'll have patients with rheumatoid arthritis or any of the conditions. Ankylosing spondylitis is another one that comes to mind. Right. But even when I see autoimmune thyroid disease or other kind of autoimmune issues, we always have to have a little heightened awareness that there may be some vascular attack going on. So is this like an issue of what we call molecular mimicry, where an abnormal protein looks a lot like something that our body normally has, and that's what incites this response? Or is there an actual disordered immune response to a normal protein or a normal thing that exists in our body that it starts to attack?
It's actually both. And if you look at it, going back to like autoimmune disease and autoimmune conditions.
Yeah, let's maybe step back and explain what is an autoimmune disease for our listeners that might not be aware.
Right. We know that, autoimmune conditions is a condition where the body is attacking itself. So you have conditions like lupus, where you make these anti-nuclear antibodies and it's attacking nuclear material, and it can affect kidney and it can affect joints, and then you have rheumatoid arthritis, where the joints are really being attacked. And you have all these autoimmune conditions. You have Hashimoto's thyroiditis, the most common cause of thyroid disease. And one of the things that we know about these autoimmune conditions is that if you have one autoimmune condition, there's a big chance that you have more autoimmune conditions, right?
Right.
We know that. So now let's take it back a step. So they always just kind of looked at coronary artery disease, or actually what most people look at is they think of it as, well, you know what? In these autoimmune conditions, they usually have inflammation. So that inflammation might be leaking, messing with the immune system, and it's helping that plaque in the foam cells. But it gets a little bit better. And this is the strength of with functional medicine and with internal medicine, in theory, internal medicine, but with functional medicine, we sometimes take a look at those associations, the associated conditions, and we try to find a underlying imbalance,
right,
that
the unifying factor.
And we found it. People with coronary artery disease have an imbalance of their immune cells called there's T-helper 17. So if your lymphocytes have different types, there's different type of white blood cell immune cells. There are two T-helper 17, which cause inflammation, and then there's two T-regs. T-regs, think of it as like, I'm regulating the immune system. I'm making sure the immune system doesn't go too crazy.
They're like the bouncers. Like if anyone gets too crazy, they kick them out.
People with coronary artery disease have been found to have higher amounts of T-helper 17 and lower amounts of T-regs. Exactly the same imbalance that we see when people have other autoimmune diseases.
Well, that's pretty impressive, because I know in the conventional world, we talk a lot about inflammation and we don't really have the immunity conversation. But what we need to realize is that inflammation comes from somewhere, right? So these white blood cells are what are recognizing abnormalities or what it thinks is an abnormality, and then secreting these chemicals. Like we talk a lot about like interleukins, right? IL-6 or TNF alpha or interferon gamma. So you're saying that in patients with coronary artery disease, we see this special type of T cell, the T-helper 17 cell, have its own dysregulation, but also the regulator cells, which are supposed to be, let's call them the rumble strips on either side. They prevent the inflammation from getting too out of whack. They stop working correctly, so you get even more inflammation. Is that what you're saying?
So the balance gets shifted, and I'm so impressed by you, man. I'm so glad you're my friend, because for a cardiologist to know this stuff, we just think of you as these like stent jockeys.
And for the most part we are, but that's why I'm the curious cardiologist asking these questions, because they need to be asked, because we can't just keep doing the same thing again and again, right? We're just going to get stuck in the same hole, right?
Absolutely.
So, yeah.
Einstein's definition of insanity. So yes. So if you look at autoimmunity, like you said, you mentioned the Tregs as being the bouncers. Autoimmune conditions need a couple of things. One is the perfect storm, and the perfect storm that increases the chance of the body attacking itself is if your T helper 17 cells are high and your Tregs are lower. And you can study that in people with coronary artery disease. As a matter of fact, the more the ratio is off, that's been correlated with a more unstable plaque, a plaque that's ready to pop. The plaque doesn't cause the problem unless it gets to 95%, you know better than me, but it causes a problem if it pops. Because if it pops, that plaque in the blood vessel, if it pops open, the body forms a clot, and that clot can overclot, and it can stop blood from flowing. It stops the flow, and that's where the stroke and heart attack actually happen.
Well, and on our side, it's a little bit more complex. You almost make it sound like a water balloon, which I guess from time to time it can. But when we look at heart attacks, they come in different types. And by far, the more common type of heart attack occurs as a result of what we call immature plaque. So when you look at a pipe of a blood vessel, right, most people assume that 70, 80, 90% plaques are the ones that rupture and actually cause blood clot. And while certainly they can, more commonly, we see these 20 or 30 or 40% plaques that aren't necessarily obstructing flow, but they're what we call immature. And what does that mean? Well, there's a lot of inflammation. They're not organized. They're not calcified. And they have a thinner cap on top as a result that can be eroded. And so as you're talking, right, what I'm seeing is, we think about these things as plumbing issues of obstruction, but really what we need to maybe do is look at biochemical markers along with scans to say, because I've been looking, and we can talk a little bit about vascular markers of inflammation, but this Treg, T helper, Th17 kind of ratio is super interesting because the holy grail of cardiology is to figure out what is the vulnerable plaque. That's what we call it, right? Which plaque is ready to rupture. But it almost seems that if we're checking this Th17 to Treg ratio on a regular basis, I might be able to tell you that is this lesion in the middle of the right coronary artery versus that one in the downstream distal part of the left anterior descending artery that's ready to pop. But what it can tell us is there's a lot of inflammation going on here. There's a lot of the body attacking itself, and this person is at a higher risk of a coronary event from happening. So we need to really dive in to diet, to lifestyle, and maybe even some medications to optimize that risk. Now, that being said, are there things that we can do to actually optimize this Th17 to Treg ratio, or is it something that we can only observe?
There are definitely things to do, but what I'd like to do is continue the story because that's just a piece of the puzzle.
That's just one piece. Sorry, I get so excited.
Yeah. No, it's not just Treg, T helper 17, and that's it. When you're so I like how you clarified that people think of it as a water balloon, but it's the smaller plaques that a lot of times are unstable and rupture. And they can think of it as if you push a balloon enough, it can pop. Yes,
absolutely.
But you can have, if you have a defective balloon or you have a damaged wall of the balloon, it takes less to pop it. Right. And that's where this imbalance, the inflammation, can make maybe a piece. We all have seen a water balloon. You blow up a balloon and then there's like a defect in the balloon.
Like a weak spot or like anybody who lives in a cold weather climate knows what a bulge in a tire looks like. There can be defects in the actual balloon itself.
So that T helper 17 Treg ratio could tell you that you're more prone to it. But here's the deal. Genetically and based on what else is around, you can have that perfect storm. And some people will have autoimmunity where genetically they go more towards rheumatoid arthritis. Some may go more towards lupus. Some may go more towards an unstable plaque. But here's the deal. You have this imbalance, and this imbalance makes you more likely to attack itself. Your body should not attack itself. But if it is thrown off, if the bouncers are gone, it's going to be easier for your body to attack itself. But what makes the body attack itself? If you look foreign, if your friend, your brother comes into the house wearing like a Freddy Krueger mask, right? In the middle of the night.
Is an old horror character for those of you who weren't born during the 80s.
a Jason mask.
Whatever, like Scream, the mask in Scream, whatever it is.
Scream mask. Thank you. So
But
somebody walks
but
in.
something has the appearance of something you don't recognize and appears threatening.
Yeah. Imagine your family member walks in wearing that mask. They're probably going to get attacked or you're going to run away or something. But if they're not wearing that mask, and you usually don't attack your family member that comes in the house, right?
Right. And I think of like a dog, like my dog who is falling asleep right here. Yeah.
So anytime you have autoimmunity, and in our patients in general, we got to think anything that makes our body look foreign is going to increase our risk of autoimmunity, especially if the T-helper 17 and T-reg is off, right? So what changes the way our body looks? Glycation, caramelization. So if you have high amounts of sugar, one of the things we look at is an A1C hemoglobin. And A1C hemoglobin is your red blood cells have protein, they have hemoglobin, and that hemoglobin gets caramelized. And that caramelization changes the way the body, that hemoglobin looks. Well, guess what? That same caramelization that happens with an A1C can happen in all the tissues of your body. And now with that T-helper 17 T-reg imbalance, now what happens is you have that change, that caramelization change. Now the body's more prone to make antibodies. The other thing is oxidative stress, so rusting. So our body, that's why we need antioxidants. If you don't have enough antioxidants and if you're making too much oxidative damage, then your body can rust from the inside. Your body will attack that as well. Guess what? When they take a look at people that have coronary artery disease and bad plaque and strokes and heart attacks, one of those markers that we look at to see if they're higher risk is oxidized LDL.
Rusted LDL, in other words.
Rusted LDL. We don't test it in the lab because we only do this kind of experimentally, but we know glycated sugar changing the LDL will change the way the LDL looks as well. Now you have that LDL that is rusted or glycated, that inflammation changes the way the body looks. So if they have inflammation from another source, it can change the way that LDL looks. The other thing that's going to change the way the body looks is if you have toxins. So toxicity can cause it. So and now I think all those things that you've looked at your whole as a cardiologist that are risk factors, now all of that can come together, adding another piece to the story that actually what's happening is you're getting a change in the way that LDL looks, which is going to increase the risk of the body attacking it. And guess what? They found in plaques, they find antibodies that are attacking LDL.
And I mean, that's a lot to take in, right? And so one of the things we say frequently in the functional medicine world is, genetics loads the gun, but lifestyle pulls the trigger. So what you're saying here is that if you're genetically predisposed to have this abnormal, as one of many dysfunctions, this abnormal ratio of T helper to T regulatory cells, that alone in and of itself can predispose you towards a more aggressive response, but it's in fact a lot of the lifestyle issues that we look at, right? So there is now here a link, I think, between what we call the cardiometabolic syndrome and cardiovascular disease, right? We're always trying to link these, but when I think of cardiometabolics, as you mentioned, I think of elevated glucose, right? And I think of these glycosylated hemoglobin like barnacles that sit on a ship, right? So you've got these barnacles living on these LDL particles on the outside, and you've got oxygen rust on there. And your body, we talked about it before, these damage associated molecular patterns or DAMPs, that's what your body is reacting against. So the lifestyle changes that we have, or the standard American diet and the lifestyle choices that put us into these cardiometabolic situations. And I want to get back to the toxicities here in a moment, environmental exposures, because I think that's hugely underrated, but or under-recognized. So the lifestyle that we live with high glucose and a lot of these processed foods and all of these things make our bodies a little bit more unrecognizable to our own immune system. So even if you just have this propensity, there's a lot that we can do with diet and lifestyle to optimize our health. And we see that time and time again. And that's why whenever you look at the guidelines for insulin resistance or cholesterol or hypertension, at least in the good old days, the first thing they recommended was 3 to 6 months of aggressive diet and lifestyle intervention. And maybe we can get into this in a moment, but now unfortunately they're going to medicines first. But I think that's not a great way to go. Getting back to what you talked about, toxicities and environmental exposures like heavy metals and things in the air. So can that affect these autoimmune conditions as well?
Absolutely. And let me kind of add to something you said. They have a genetic predisposition, but but the genetic predisposition is that they're more prone in certain lifestyles to have your T helper 17 go up and your T regs go down. So there are things that like there are things that are done, like sedentary behavior, like bad bacteria in the gut, like toxins. There are things that will make T helper 17 go up and T reg go down. It's not so that T helpers, you can have identical twins, and one of them has their T helper 17 up, T reg down, and the other one has them normal. They have a good balance. They have enough bouncers. And I'm glad you said bouncers. I think that's a great analogy. So let's talk about toxins.
Yeah.
Environmental toxins change the way that your tissue look. If you change the way your LDL looks, what's going to happen when that LDL, and sometimes we'll get small density LDL and you have inflammation, and inflammation makes it leak in the cracks easier. And then what happens is the glycocalyx, which is the slimy hair on the wall of the blood vessel, when that starts to get destroyed and now that LDL sneaks in there, well, guess what also what happens if that LDL there's toxicity and it changes the way that LDL looks, you have antibodies that are attacking it as well. And now these antibodies are pulling those macrophages in and pulling the other immune cells in.
Yeah. Wow. That's pretty interesting. And I don't think that cardiologists in general are looking at things like heavy metals and toxins. And it's something that I had a case once of a gentleman who was a baggage handler. I live here in Orange County, California. So at our airport called John Wayne Airport, and he was a baggage handler. And I asked, are you exposed to chemicals on a regular basis? And he said, Doc, I don't know when I'm not exposed to chemicals. And we ended up looking at his heavy metal screen. This is as I was doing my functional medicine training, and everything was off the roof, right? It was, everything was abnormal. And he had blood vessel issues everywhere. And so we put him on a protocol to try and reduce, you have to be very cautious with these heavy metals, right? As you detoxify somebody, but put him on a detox protocol, and, his blood pressure got better. And you mentioned that weirdo thing called the glycocalyx, but my assumption is that everything got a little bit better. Let's, take a time out here and address this issue of the glycocalyx, because it's something, again, that not a lot of cardiologists certainly, but I think also not a lot of just even general practitioners, family practice, internal medicine, primary care type docs are aware of. So normally when I think of the blood vessel, I think of 3 layers of actual blood vessel itself. There's the outside called the adventitia, the middle called the media, the inside called the intima. And then for years, I would say, then there's a layer of shag carpeting on the inside, this single layer cell called the endothelium, which we've learned a lot about. It secretes nitric oxide, is the gatekeeper for what comes in and out of the cells, and has a lot of very physiologic functions. Also, one of the earliest manifestations of coronary disease, abnormal vessel function, is something we look at called endothelial dysfunction. But now there's this newly described layer even inside or on top of the endothelium, kind of between the blood and the endothelium itself, called the glycocalyx. Like, what's the deal with that? What is that all about?
Yeah, it's pretty interesting. So it's slimy and it has hair-like projections. And if you want to go even further, there should be a negative charge. And you want to go even more into it, it may be creating, which is called, it looks like water can be in 4 different states. We know that it can be in a solid, a liquid, and a gas. But another state, which is the state they think clouds are in, is called the easy state.
Right, exclusion zone, right?
The
Is what
exclusion
called,
zone,
yeah.
yes. And when that happens, then the molecules of water are so tightly kind of together that nothing can move around it. Well, guess what? That glycocalyx one of the thoughts is that it creates that easy zone water. And if you look under a microscope of a blood vessel, a healthy blood vessel, you'll see particles in the blood itself that are flowing, but you'll see next to the endothelium, next to the glycocalyx, you'll see an area of water that has nothing in it. And the glycocalyx, as it starts, if you don't have enough nitric oxide, if you have inflammation, if you have higher blood sugar, if you have oxidative stress, if you have all those things, what happens is that hair starts to deteriorate. And as it starts to deteriorate, and the toxicity and the inflammation will open it up, and now the cholesterol can leak in between the crack, causing issues.
So yeah, in the functional medicine world, I think most people are very aware of that concept of leaky gut and the lining of the gut and the junctions between the cells breaking down zonulin and all these things that we talk about. But yeah, for years I've been talking about leaky vessel, and I think that even before we start to see endothelial disruption, meaning of the cells, and I think this is still an evolving field, kind of understanding the glycocalyx, that layer on top. And you mentioned these projections and things. I did a little bit of research into the glycocalyx for a talk I did a while ago. It's amazing because these projections aren't just passive. They're like antennas sending data into the cells about shear force, right? So if your blood pressure is higher, you get more of a push on these starches or these antenna that are sticking out. So it tells the cell, you know what, the blood pressure is high. We need to relax a little bit to lower the blood pressure. It gives information about the viscosity and the osmolality, the concentration, the thickness, all of these things. So it's an area of great fascination. At this point, is there a way to test the glycocalyx, or what do we just know this as a thought experiment, that this is something that exists, or are there things that we can actually do to kind of heal this? And if we could just bring it back to our original topic, how might that relate to then this autoimmunity business that we're talking about?
Yeah, so the same thing that causes autoimmunity, like oxidative stress and glycation and toxicity, also damage the glycocalyx. Now, they do have these devices you kind of put under your tongue that may be able to help, but I think that it's exciting. I'm not sure how reproducible they are. I know you'll get people upset that will argue with me because they have the machine. That doesn't mean I wouldn't do the test. That's not that, but I just don't think that we're fully there yet, because as you know, you could have skip lesions. You can have maybe in your mouth, you have an area that looks okay, but then further down, you have an area that doesn't look okay.
Different sizes of blood vessels may kind of have different levels of pathology and compromise. Yeah.
Right. So what I like helping with nitric oxide boosting. So there are supplements. I do work for Human, as that's part of my kind of part-time gig. I'm their medical director. I help them with making formulas and education and things like that. And they make a product called Neo 40 Professional, which actually helps. It's designed to boost nitric oxide. And they also make a supplement called glycocalyx. And what it has in it is fucoidin. It's a brown seaweed extract that is thought to really help build that glycocalyx. It has in it it's a French melon extract, which has something in it called superoxide dismutase, which helps there's something called superoxide that can damage the blood vessels. So it helps with that. It also has a black garlic extract, and that helps with hydrogen sulfite. It helps increase hydrogen sulfite and helps with nitric oxide.
So there are nutraceuticals right now available that we can use to kind of heal the glycocalyx, which is interesting. And then, so it's not just medicines, and these may be, would these be natural substances that we could even get from food, or do they not exist in high enough concentrations in food? Like you have to eat 1,000 French melons to get what you get in a supplement like this.
You need a lot of French melons. And the reality is that you're like taking this concentrated product from the foods, because our food has been changed so much. You're kind of evening out the score a little bit because of how they've changed and corrupted our food a lot.
So is a French melon like a melon with a beret? Is that kind of how I recognize it? It's a store. It's got like one of those.
It's a fancy, and I haven't
one of those cigarette holders or something like that.
And listen, I'm not fancy like you. I don't really eat brown seaweed, but I mean, go for it, bro. Tell me how it is.
I think I accidentally probably eat it when I go surfing and I fall into the ocean or something. So, all right. So things, we kind of veered from the topic here, but getting back to the autoimmune issues.
Yeah.
So now, is this something that you can test in clinical practice? Like, let's say as a cardiologist tomorrow, I get a patient who says, you know what, doc, I am, in my mid 40s. My dad had a heart attack when he was 52. I want to optimize my health. I run marathons and I do all the right things. I make reasonably good dietary choices, but I want to optimize whatever I can. So is this something that clinically that you test on a regular basis? Is this still meaning this T17 to T regulator cell ratio? Is this something I can like send out to specialty labs and get a better understanding?
So it's more on the experimental realm, like it's more in experimental labs. So it's not something that you can get readily, but let me tell you this, because it's not, you could have that T-helper 17 T-reg imbalance, and it's not really causing a cardio issue or a different issue. We can take it a step back. And what we can look at is we can indirectly look at the things that change the way that our body looks. Well, first of all, If you, when we check, you can check an advanced lipid panel, and on your LDL, which is normally called bad cholesterol, and it's really not bad. You need it for life. But if it's
Right.
dysregulated, it's bad. When you look at that, you can tell if it's the really tiny ones, those are more likely to go through those molecular changes like caramelization or rusting. And those little ones, if you see they're high, that's a red flag.
And so that's that small, dense LDL is what you're talking about
Yeah,
there.
yeah.
Yeah.
I
Yeah.
also will check what's called a hemoglobin A1C, which is what you check usually in diabetics. And if
Right.
that number is high or even borderline, that's telling you that sugar is changing the structure of things. And I can then say, well, if it's changing hemoglobin, it's probably changing LDL.
Right.
And you can check my cholesterol panels that I get with through the regular lab. I'm taking a look at what's called oxidized LDL. You can actually, I'm sure you look at them, you can see that LDL is rusting. And by seeing that actually tells you that once your body starts changing the way it looks, it's fair game for the immune system to attack it.
Well, and I think there's so many markers, right? I mean, if you think about like, there's a book called Drop Acid by Dr. Perlmutter, right? Looking at uric acid as a marker of, basically, I think of it as a marker of oxidative stress. You mentioned hemoglobin A1C. So,
Yeah.
Even if you don't have these advanced labs, and it's funny that you call it advanced lipid panel, because I just call it a comprehensive lipid panel. I'm not really sure why every cardiologist isn't checking that on a regular basis as just a matter of, a standard kind of lab test. I think it has, unfortunately, a lot to do with insurance and reimbursement, but you don't necessarily need to have these advanced labs to know that your body is out of balance. So as we're kind of getting towards the end of our time here, what are some of the dietary and lifestyle modifications? I mean, I almost feel like we beat the same drum no matter what the condition, right? We talk about a cardiometabolic diet, lowering glycemic impact, increasing our antioxidant intake, phytonutrients, optimizing sleep. So what are some of the heavy hitters that you use in your practice if you do have someone who has a high oxidative stress burden or are out of whack in terms of their cardiometabolics? What are some of the things that you enact as a physician and that maybe some of our listeners can do tomorrow to improve, maybe not reverse, but at least improve their biochemical status?
Okay. Well, I think, well, let me add one more piece that we didn't talk about. You
Sure.
talked about it in the beginning, and that's molecular mimicry. And molecular mimicry is where maybe there's a bacteria in your gut, or maybe there is a area in the food that we eat that looks similar to the body. And then when you take that food in, something like gluten or casein from dairy, when you take that in, the body sees it, attacks it, and then can turn around and attack any part of your body or LDL. So if the person has an autoimmune condition, we're going to follow the same protocol because it looks like it's the same process that's happening. And that gives you it. So you can bet that if somebody has an autoimmune disease, that their T helper 17 and T reg cells are out of balance. I don't know if I mentioned this. I just, for completeness sake, when people have a stroke or a heart attack, they've tested the levels, their blood levels, right after the heart attack, and their T helper 17 shoot up and their T regs drop, which is even more pushing towards this autoimmune thing. So let's take a look at T helper 17. What can help lower T helper 17 that's out of whack? Omega-3 fatty acids, optimizing vitamin D through sunlight or through supplementation. I always add vitamin K with my vitamin D. Improving sleep. These are all things that are studied in the research. Stress management. And I'm sure you're going to love this one, cold exposure. You take those cold showers?
I grew up in Chicago. I'm done with cold, but there's so much, but there is so much data for cold and controlled stress, hysteresis, all of these things to help drive up your body's ability to heal itself. So I would expect myocardial infarction to be no different or stroke to be no different, right?
Now you want bouncers, right? So that was decreasing the soldiers that are just going a little too crazy. Now we got to up the bouncers. So you up the bouncers through probiotics, through EGCG found in green tea. So 10 cups of green tea, or sometimes you take a supplement of EGCG.
10 cups would probably keep me awake for a month.
Yeah, you could do decaffeinated, but who knows? So, but you can do like a decaffeinated green tea extract.
There you go.
Curcumin, if you like curry, man, load
turmeric, the spice of my peoples.
Vitamin D and intermittent fasting.
All right. So actually a lot of things that I think we talk about in general, right? I mean, like adding these spices and herbs, and a lot of what I talk about in my metabolic program that I run, Well 12, is really these basic kind of lifestyle habits and these basic foods that have these healing properties above and beyond being healthy for you. And so we see that here with that discussion. Anything else that we need before I have a rapid fire series of questions that I always end my podcast with to help get to know us? So as we're talking about autoimmunity, anything else we didn't touch on today?
Yeah, what I would say is we make sure that you're looking at a sugar panel, which is checking. You want to check a C-peptide, an insulin resistance score. You do all the things to lower that. You make sure that you're healing the gut. You make sure, like you said, there are things that we give to help detoxify. So it's you kind of take a look at all the data and all the clues, and then you work on that patient's individual, and then take cold showers again. Stop it! Come on. I need you to be tougher.
It's funny. At my gym, I started swimming again, and they converted one of the hot tubs into a cold plunge.
It's a sign, dude.
I guess, and as someone who is a cardiologist, now functional medicine doctor, but also someone who suffers from genetically just nonsense lipids, I think I need to take that into account. It's almost like, I can look, I eat a piece of celery and my triglycerides shoot up. I mean, it's crazy. And particularly in Indians and Southeast Asians, it's kind of rampant. So, I mean, I think this is a really interesting discussion. I mean, a lot more kind of moving on. I remember you told me about this TH17 business years ago when we first met. The remarkable thing is none of this is necessarily new, but there's a gap between what we know from the basic science world and the clinical world. And unfortunately, a lot of times I feel, and correct me if I'm wrong, but I feel that unless there's like a medication involved, we don't really get to this level of knowledge. But that's not to say it's not actionable. I mean, I think the things that you said, cold plunge, diet, reducing your glycemic intake, eating more fruits and vegetables, sleeping, detoxifying your life of electronics and stress and toxic people, and all of these things really kind of balance us out. And that's what I love so much about being the Curious Cardiologist, is that no matter what the condition, it could be neuroinflammation or kidney disease or whatever, we're always coming back to the same things, right? Which is live how we were designed to live, not live like how modern society tells us we live, right? Or it tells us that we're supposed to live. So, all right. So I always love, obviously we know each other pretty well, but I always love kind of these rapid fire at the end of the session questions. So I'm going to ask you a couple things, nothing crazy or incriminating, but just want our listeners to get to know you. So first question, what is the weirdest or most unforgettable place you've ever visited, like traveled? Wow, you're going back. You must be well traveled.
I'm going back. So I think unforgettable. I went and spoke to there's a hospital in Saudi Arabia, and they had me come and speak to the doctors there. And there is it was in the city called Jeddah. Jeddah in Arabic actually means grandmother, and the reason is because it's thought that Eve's tomb is there. So I remember there was a time where so you get deep into like the old city, like they kind of preserved it. And I remember walking, and there's shops and there's people going back and forth, and like the call to prayer is happening, and there's this ancient mosque that's like 1,000 years old. And I remember just walking the streets and saying, man, this is what it was like thousands of years ago.
Like at the beginning of time. I've had that episode. Actually, for me, it's when I visited the pyramids in Egypt. And I was like, wow, this is amazing. But these are the same footsteps that people took like thousands of years ago. And we just don't have that here in the US, but you go to like Greece or Rome or any of those places, or even in India, going to, the Red Fort and areas that are historical for us. So, all right. So that's interesting. Next question. If you could only eat one meal for the rest of your life, what would it be?
I mean, can I just have pizza, or does it have to be healthy?
I mean, it's up to you. It's your life. So the rest of your life, you could extend it as long as you want by eating kale. Although I don't think, a life having to eat kale is not worth living, or whatever you want. What's your favorite thing to eat?
Yeah, it's going to have to eat. It can't be, I was going to just say, give me a protein shake with everything I need. Let me toughen it out.
I guess that's fine. Bowel movements might be kind of weird, but
I'll
that's
tell
cool.
you, I don't eat it, but I'll tell you one of my favorite foods.
Yeah, go for it.
One of my stuffed grape leaves. If done right, stuffed grape leaves, the best. Especially if it's like a Palestinian, Lebanese, Syrian kind of, they know what they're doing.
Hey, who invented hummus? Let's not get into that. Next question. What's a health trend you secretly love and one that you think is probably overhyped?
What I love is getting those 10,000 steps in and just going for walks. I think that's amazing. I think overly hyped. I'll tell you. So the supplement bergamot, it can work for some people, but I think it was so overly hyped. We were expecting it to do a lot better, and it really didn't.
Yeah, for me, it's niacin. I've never really had great experience with niacin. Like tried it myself. All right, if you weren't in medicine, what do you think you'd be doing right now? If you weren't a doctor,
I'd probably be stand-up comedy.
I could see that. And finally, what's the last thing that made you laugh out loud? Like really gut belly laugh out loud.
Dude, didn't you just make me laugh? I think this show, man.
Partly comedy, partly informative. I guess that's why they call it edutainment, right? Well, right. Hey, Dr. Elyaman, Yousef, it's so weird to call you by doctor name, but hey, so great to have you. Thank you for being our first guest, and thank you for such an interesting discussion about something that I thought I knew almost everything about, being coronary artery disease, and putting a completely different spin on it. I mean, I think that there's probably maybe a handful of people on earth that approach this idea of coronary artery disease and with an autoimmune mindset. But I think it's part of what we need to do, again, as a goal of the podcast, is really looking at old things in new ways. And, we think we know everything about coronary disease, but realizing that there is this imbalance of T cells in our body that may predispose us, and looking at lifestyle and things that we can do to optimize this, I think is hugely important. So thank you so much for being here. We have the opportunity to hang out and be on each other's podcasts many, many times in the future.
Yeah. So Dr. Cece, Curious Cardiologist, Dr. Curious. No, I would encourage the audience to take a look at my first podcast, the FMP Essentials Show. If you guys want to follow me on social, it's at Dr. Elyaman, or just look in the comments of Dr. Sanjay's stuff. So I'm usually commenting as well and liking stuff. And yeah, no, thank you very much. I'm honored that I'm your first, because sometimes it's not a mutual, like you're the guy I called first, but like, right. Are you going to call me first? But now I feel fulfilled. And now that I've given you everything that I know that you don't, I'm going to have to learn some more stuff.
Well, the circle is now complete. So it's been awesome having you. We'll link all your things in the show notes. For those of you who don't know, Dr. Elyaman does run Functional Medicine Essentials, which is a great resource for practitioners. In fact, just did an amazing masterclass on lipids that I even picked. I thought I knew a lot about lipids, but I even picked up some things. So keep out there, keep educating. We'll definitely put links to all of your things in the show notes once I figure out how to do show notes. But again, thank you so much for being here. And everybody, thank you guys for being here as well. I hope that this was an exciting discussion, the first of many we'll have on the podcast. If you like what you heard today, please subscribe to the podcast. So click the subscribe button below and leave comments. I love to engage with you guys and learn your thoughts about what we talked about. Are we genius? Are we madmen? Are we full of wisdom? Are we full of crap? You guys can help me decide. And what I've learned is the internet is not bashful about sharing their opinion. So definitely put your comments down. Let me know what you're thinking, and I will catch you next time on the Curious Cardiologist podcast. All right. And stop.